Hello, everyone. This is the fourth shoulder board. Today we have 286 participants for this shoulder board. I think that the topic is very attractive and is still relevant, and always many discussion because complex humeral fracture always in many societies meeting we discuss a lot. So for that, we try to collect the famous experts of the world because they did a lot of publications on the subject. And I would like to present Bernhard Jost from Switzerland, Saint-Gallen. This is a very nice place where I started the orthopedic with AO. Thank you, Bernhard, to spend time for this night. Carlos Torrens from Barcelona, and he's very famous regarding acute fracture or chronic because he did a lot of publication with his team. And thank you, Carlos, to spend time with us. And Joaquin from Mayo Clinic, you know very well, and he published a lot on the plate for fixation. And this is a very nice friend, and he spent 1 hour during operating day to present his case with me. So the last one is Pascal, and he looked for the link, but no problem, he will with us. We start with the first case. This is a patient. This is a very young patient. He's a male. He doesn't do any sports, and he was a very big trauma, ski trauma. It's not this year, but last year. And with these emergency X-rays, this is dislocations of the humeral head with a fracture and with a comminution of the great tuberosities. So there is, in emergency, there is no axillary lesion, no neurovascular lesion. And previously, before the trauma, there is no history of this shoulder. So this is the X-rays in emergency. The quality is not so good, but we did immediately a CT scan. But you can see here that there is a problem with the humeral head, with the humerus. There is a problem of the great tuberosities, dislocations. And we did this CT scan and a 3D reconstruction. You see that you can analyze better the fracture. I think that the curve was good because there is no problem. He's 39 years old. He's a very young guy, a very big trauma, sky trauma. And I think that I propose you to vote because you see that I summarize with X-rays and CT scan. And I propose you osteosynthesis or arthroplasty, anatomic or reverse. And the expert will answer or propose what we have to do for these patients for the best results. Maybe my first question is for Bernhard, because Switzerland, ski, trauma, you are very expert regarding that. And what do you think about the strategies, the therapeutic strategy, Bernhard?
Do you mean before the reposition or now? Because he is so medialized, the dislocated head. So in this situation, we usually do a CT scan before the reduction to see whether there is a fracture subcapital. And if we have a fracture subcapital or we fear that there is a fracture, we do the reposition only before the OR, just when we can go to the OR. And we usually try to go with the finger in the axilla and reduce the proximal humerus, the head with that. So because we exactly fear the situation here, because this is now a much worse fracture than it was before. In this situation, 39-year-old, of course, the head is probably devascularized, no blood supply, but I would probably take the head out and try to reconstruct the shoulder with an osteosynthesis, and we prefer a plate in such a situation.
And so you feel that having a CT before the reduction helps you reduce better without opening, right?
Yeah, and you have to it depends when it is coming. If you can immediately go to the OR, I just probably would go for an open reduction with that. If there is a fracture subcapital. If it's at night that nobody is here, you usually can reduce that fracture when you put the finger in the axilla on the head, and you can guide the head back to the cavity. And then you can fix the fracture later if needed. So that prevents you from displacing the head, or that the head remains in the axilla.
Can I make a comment, Jean-David?
Sure, of course.
So when I was working still in Madrid as a resident, sometimes we will have a big delay between seeing the patient in the ER and then taking the patient to the operating room. So something I did back then, which I haven't done for a long time in this situation that Bernhard is talking about, is when you're going to do your reduction in the operating room, place 2 percutaneous pins through the shaft into the head, just so that when you move the humerus, it moves as a unit. And when I did that, it wasn't very common, but it was successful. So I think that even if you do the reduction in the operating room under general anesthesia with muscle relaxation, the head may still lay behind. So you're going to try to do it because you think, this patient, I cannot get to him or her in the OR for several days. Placing those pins may help you avoid the disruption between the head and the shaft.
So you put a percutaneous pin in the head, that medial?
Through the shaft into the head, and you have to do it under fluoro, because of course the brachial plexus and the axillary artery and vein are right there, so you cannot do it blindly. But having some metal connection between the shaft and the head may decrease the chance of displacement, because oftentimes there is a fracture at the neck level, but it's hidden, so you can't see it,
So you drill oblique from inferior to superior, right?
Temporarily, it's not a permanent fixation.
Yeah, of course.
And sometimes you get lucky, and once the whole proximal humerus is back in the glenoid, the tuberosity is actually sitting okay, and sometimes you get lucky and you don't need to do surgery. Rarely. So just for people that are in the situation. Now, if you have access to 1 hour where you can do surgery, I think what Dr. Jost said is better. You just do the reduction, and if this happens, you just go ahead with either fixation or arthroplasty. But in places, around the world where you don't have access to 1 hour right away, you don't want to leave the head displaced or dislocated for 10 days, that may help people.
But so if you have access to an OR, you bring the patient to the OR straight away, and you try to do your pin thing, or you try to reduce it with muscle relaxation, or you open him straight away?
So what I'm trying to say is that if you work in an environment where you will not have access to do interpretation or arthroplasty right away.
But if you are in your perfect environment, what would you do?
I would prefer to be in the OR ready to do a hemiarthroplasty or internal fixation or reverse, whatever they choose to do right away. But I see people connected in the chat that are from all over the world.
Yes, of course.
People don't have access to an OR right away. So you don't want to leave the head dislocated 10 days, but it's very difficult to avoid the displacement that happened in this case if you don't have some type of metal stability when you do the reduction.
And is it a possibility for you to do a minimal deltopectoral approach and with your finger try to reduce and then just close if the reduction looks fine?
I think it may be possible, Jean-David, but I've never tried that. So I have no experience, never thought that.
You don't even need to open. What I mean is not open, it's a closed reduction.
Yes.
You feel the head in the axilla.
Yeah.
And if it stays okay, you can leave it. But
I try to teach my residents every year, every month, but it happens every year in my hospital. So I fully agree with Bernhard that if we suspect that, we need to have a CT scan and then do reduction under fluoroscopy in the OR. And then the only thing I would do completely different is I would do, if this is the case, I would do an open reduction, and then I will fix it with 3 Kirchner wires, because I don't want to plate it with the risk of vascular necrosis. And sometimes it's not so painful if the vascular necrosis comes in, and maybe the screws are out and are eroding the glenoid. So I think it's a young guy, so probably the fracture will heal within 3 to 4 weeks. So I just do open reduction and then fixing with Kirchner wires, and that's it.
And so your K wires, you put them from lateral to the head.
Yeah.
Under the greater tuberosity.
Yes.
And you don't try to fix the greater tuberosity.
No, and then bone sutures.
Okay.
Pascal, thank you to be here. What do you think to manage in acute fracture?
So this is something that you should manage as soon as possible, as you said. And the problem is the dislocation of the head, which is very low in the axillary fold, and there is a risk of vascular plexus, brachial plexus, and vascular lesion. So I think in this case, I would do a deltopectoral approach. And then I would be very careful when reducing the head, taking the head, be ready to do an osteotomy of the coracoid if needed to control the vessels, because it happened to me once to have a lesion of the vein, axillary vein, and an artery, and if you don't do an osteotomy of the coracoid, it's not possible to control the vessels. Then if there is no vessel problems, the decision-making process is between doing a conservative treatment, either plate or nail, or prosthesis, and in a young person it would be a hemiarthroplasty. But for me, it would be probably to do a nail, because as I always said, the only reason to operate a fracture is not the head, it's the greater tuberosity. I want the heel, I want the greater tuberosity heals in good place, so the cuff will remain intact. And if the head necrosis, it's not a problem. I can remove the head later and do a prosthesis. But if the tuberosity doesn't heal in the right spot, the cuff will be non-functional, and whatever you do, a hemi, a total, or reverse, it will be a poor result. So my goal is to obtain healing of the greater tuberosity and the head if possible, although there is a high risk of necrosis of the head. I have seen cases like this where the fixation was done with a nail, with the nail that we designed, and then in a young person like this, and there was no necrosis at the end of the day. So the problem is that if you do a plate and if you have a necrosis, you're going to destroy the glenoid. And as you know, the nail that we designed, in the nail that we designed, the screws are not oriented toward the head but toward the tuberosities, so there is no risk for destroying the glenoid. First, do no harm. So I think it's important to make sure that you will be able to get bone healing of the tuberosities, and especially the greater tuberosity, because on the greater tuberosity you have three major muscles and tendons: supraspinatus, infraspinatus, and teres minor. So the shoulder cannot work without these three muscles.
When you do the operation, and I agree with you that the exposition of the axillary part is very difficult, and osteotomy of the coracoid or lengthening of the conjoint tendon is very useful to avoid the iatrogenic lesion of the plexus. I agree with Pascal. So if you consider that the head is without any capsule, because the migration is very distal, do you have tips and tricks to know if you do a reposition of the head, there is a necrosis or no necrosis? Do you have tips and tricks during the operation to evaluate the future of the head, Bernhard?
No, I think the head is devascularized, that's true. But you can see, you can observe, and it happened to me, I've seen that, exactly the same case where we fix the head and there is creeping substitution of the bone, and it participates to the healing of the tuberosities anyway. And as I said, if there is necrosis, secondary necrosis, that's not a problem unless you have rigid screws directed toward the head, the glenoid. Then you will destroy the glenoid, and that will be a problem, because then you cannot do a hemi anymore. You have to discuss a total. It cannot be anatomic total. It should be a reverse total, and it's a disaster because it's a poor reverse total in a young person.
Let's have a question for all of you. Do you decide before, or do you decide intraoperatively if you're going to fix or do a hemi?
Personally, I decide before, and I go and fix it.
So you have no more indications for hemi if this is not an indication for hemi?
Yes, but he's 39. Is your
yes.
Maybe you're younger than that. But would you like to have a hemi, or would you?
No. But so the decision for you is age.
Yeah, of course.
Okay.
Of course.
For me,
do you have a comment?
I was going to make two comments. One is I want to emphasize what Dr. Boileau said. It is true that you can have a real bad day in the operating room when someone bleeds badly from the axillary artery and vein. And I like your idea, Pascal, of the osteotomy, but another option, if you are really in a crunch. So if you're going to plan to do it, I think an osteotomy is better. But if you're in the operating room and there is already brisk bleeding, you can also cut the conjoint tendon. And the repair with sutures is actually very effective and it's very, very quick. So one thing to keep in mind, maybe you don't have a saw or an osteotome right there, but we all have a knife. So one other way to get to the head is to cut the conjoint tendon of the coracoid if you're in a true emergency. And then the second point is that I'm going to disagree with Pascal, and this is what makes this case fun. I think the risk of necrosis is very, very, very high. It's not 100%, but it's high. So I myself probably would do a hemiarthroplasty in this patient. I don't think I would try to fix it. And I really like the idea of Carlos and Pascal that if you fix it, don't use a locking plate, because those screws are going to destroy the head and the glenoid. So either pinning like Carlos said, or maybe a nail like Pascal said, but if I'm going to fix it, no locking plate, that's for sure. But I would prefer a hemi myself.
Okay,
But
Carlos, what
surgery
do you
is
decide,
like, so as I always say, I mean, surgery is like love, you know? There is no never or always.
Correct.
And I can show you exactly the same CT scan with the head fixed with the nail in a young lady performed by Armand Atzidakis in Denver, Colorado. And you can see she has a normal motion and no necrosis of the head. And again, if the head necroses, but the tuberosity and the cuff is perfectly reconstructed, no problem. You do a hemi and you have a very good result. So I think the key point is not to, as you said, don't put any rigid rigid metal directed toward the glenoid to not destroy the glenoid.
By the same token, I can also see x-rays of patients that had a locking plate and the head is destroyed completely. And I think a hemi for fracture, if the torsion is healed, the survivorship is very, very long. Like, I don't think we have failures before 10 to 15 years unless the patient is very aggressive. So I think a hemi may be one operation that is all that the patient needs, maybe.
Carlos, please, how to manage that? Plate, nail, or hemi, or anatomic?
This case, I would do a Kisner wire. I would do open reduction, put everything in place, and then do some osteosutures around tuberosities, and then fix with 3 Kisner wires from the shaft to the head. And I will remove it within 3 weeks, because it's a young guy. So probably it will be strength enough to start doing rehab. And I don't want a plate in there.
What diameter K wires you use?
Sorry?
What diameter of K wires do you use?
About 2 millimeters, something like that. But it's not a big problem. It's, the thing is to get everything reduced and then just fix.
Okay,
Bernhard, you stay plate now after the discussion?
Yes, so last but not least, I would use a locking plate. And you're absolutely, I absolutely agree. You have to follow the patients. Now, I have cases with these. I have cleaned the head on the table and put it again on it. And what Pascal said is exactly right. You need to fix the greater tuberosity in the right position, and it has to heal there. And you can use a locking plate. He is young. You don't need 2 long screws. You can fix, and you have to follow it. And you have to remove the plate as early as possible, meaning after 4 or 5 months, to avoid exactly what you have said, that they have a cutout. And then it's possible. I have cases with a partial necrosis, not a completely closed. In such situation, after removing the plate, they were pretty fine with their function, and they did not the prosthesis so far.
And do you prepare autograft or allograft before?
Usually not. No, these are so young guys with such good bone. Usually they heal without an allograft or an autograft, something. So, but you need to have a stable fixation intraoperable. If you don't get a stable fixation, then I probably would convert to a hemi, which would be very painful in a 39-year-old. But the interesting question is, when would we go immediately for a hemi or for a prosthesis? At what age or in what situation? Exactly such cases.
Yes, Pascal. What is your cutoff for the age, approximately?
It's the physiologic age and the activity of the patient. You know, you can be 39-year-old and be very old in your head and in your body. Sorry for that. And you can be 39 or 49 or 59 and be very young. So I think it's more the physiologic age and the activity of the patient, which is important. But coming back to what Bernhard said, I mean, Bernhard, you agree that by putting a plate on the lateral part of the humerus, you will participate to devascularization of the bone. So if you can get the same result with something which is a strut, which is inside bone, which support the head and fix the tuberosity, why not choosing it? That's what I don't understand. I know that you are Swiss. I know that a Swiss cannot see a fracture without a plate, but still, I mean, do you ever think about changing your mind one day?
You know, you want to put me in the corner of the AO. I'm absolutely not an AO guy, but I'm still Swiss. I try to avoid Swiss because I was announced as Germany in the program, but I'm still Swiss. But anyway.
I'm just teasing you.
I know. But, you know, I think it's also a matter of philosophy or religion. You know, you have the nailers and the platers. There are pros and cons for each of them. I'm not good in nails, but I'm not so bad in plates. And in my clinic, people have to use plates and not one a plate, one a nail. I think that disturbs the outcome. So if you do one thing right, then it's okay. If you for the other, it's okay too. So plate and nail are in the literature always the same. So
I give you the result of the poll. It's very interesting. 62 attend this vote, and 50% osteosynthesis by plate.
Of course. I'm not surprised.
34% hemiarthroplasty, and only 12% for nail. But I think that the problem of the nail, I know very well because I promote the nail, maybe for many people is difficult to use in this complex fracture. I don't understand why, but many people say, oh, a nail is very difficult in this situation. I prefer to put a plate. But I think that I would like to show you what we decide to do with Dr. Deeb, and we decided to do hemiarthroplasty. The key point, I agree with Pascal, Bernhard, and Carlos. The key point is great tuberosity, the cuff, and you have to repair very precisely the cuff. And this is after 6 months, you have a good healing of the great tuberosities and good position of the prosthesis. And as described by Pascal, never and always in surgery, it doesn't exist. We can obtain the same result with a nail or with hemiarthroplasty. And you think that the discussion is very, very, very important because he's a young guy and I don't know the future of the hemiarthroplasty. Maybe we have inflammation of the glenoid after 5 or 10 years and we have to change. But you see that the result is very nice regarding external rotation and internal rotation, and he has a very nice result.
Philippe, can you tell us how did you do the rehabilitation? When did you move the shoulder after this operation for this patient?
No, I immobilize for 4 weeks with sling in neutral rotation. It's very important in neutral rotation. And after we start passive during 1 month, and active after 2 or 3 months. And I think that it's many times I don't want to start very, very immediately, but in fracture, I prefer to immobilize the patient 4 weeks.
And then for Pascal, if you did a hemiarthroplasty, Pascal, would you do a pyrocarbon head or not really?
Yes, I would probably put a pyrocarbon head, making sure that I undersize the head. That's the key point with the pyrocarbon, because as you know, you need a metallic platform under the pyrocarbon to support the pyrocarbon itself. And because of that, it increased the thickness of about 2 millimeters with the pyrocarbon head. So you really have to think about that and to undersize the head. Otherwise, you will overstuff the joint. And as you know, overstuffing of the glenohumeral joints means glenoid erosion and pain, and then cuff tear as well, or subscap rupture.
Bernhard, you said that sometimes you had to remove completely the head on the back table and then put it back in. That happened
only sometimes.
Yes, and can you?
That happened to me in a actually very similar case where it really the head was completely denudated, no capsule around it, and we didn't want to put the prosthesis and try to orientate the head and to fix it with tuberosity, and it worked. But we were prepared for a hemi.
And can you describe how you do that technically? Like, so you try to, how do you have tips to orientate the head correctly? Do you fix it then to the glenoid? You pin it?
Yes. No,
and then
not to the glenoid. No, I try to orientate the rotation of the head. You can check on the proximal humerus with the fracture line, and maybe you can identify where it belongs to. And then I fix in the position with some K-wires and put the tuberosities together, and at the end I put the plate. I come with the Kirchner wires more from anterior, that I don't interfere with the plate, but always prepared for a hemi if it does not work.
So first you try to stabilize the head to the shaft, right?
Yes.
And you, Pascal, your entry point, sorry, Philippe, but first you try to reduce the head, and then you have a big gap between the head and the tuberosities, and this is where you put your nail in the middle, or you try to put it in the head?
It's very important. Your question is very important. You have to enter the cartilage. You enter the head, and you have to leave a bridge of bone and cartilage about 5 millimeters lateral. Otherwise, you will break this bridge, and then you will have instability. So he's a young guy. Normally, he has a lot of cancellous bone, and if you close the book, if you bring the two tuberosities together, normally you should be able to have enough support. If not, I don't have any hesitation to add some allograft, pure cancellous allograft, under the head and around the nail to bring before I bring the tuberosity together. What is important, I think, it's to realize if there are young surgeons who are listening to us, I think what is important is to realize that it's difficult to do this operation from the front because you're from the delta pectoral approach, and you should understand that the greater tuberosity position is lateral, it's not posterior. And if you want to bring the greater tuberosity in the lateral position and fix it with cerclage, for instance, or with the screws of the nail, you have to put the arm in abduction and external rotation. So it's not so easy because you're looking from the front here. And actually, that's why it's so difficult to do a plate, I think. It's because once you put your suture on the greater tuberosity and then you want to put your plates, the good reduction is abduction, external rotation. And so surgeons cannot do this. It's impossible to do. So what they do, they come back in internal rotation. And then the greater tuberosity stays in the back. That's why I think it's so difficult to do this operation from the front, but in this case, you have to do it from the front because of the dislocation of the humeral head. But otherwise, I recommend to do the lateral, superior lateral approach, because then it's much easier to do this operation. But with the plate, you cannot, because you have to expose to all the lateral face of the humerus, and that's also another problem that you had. So for you, Bernhard, who is very used to the plate, who is very talented to surgeon, it's not a problem. But I can tell you, I have used plate for years, and I was not able to transfer my knowledge and my technical skills to my young surgeons. That's why I looked for something else at some point, because I was so disappointed that nobody was able to reproduce these results. They are difficult to get. You cannot say the contrary. And so that's why I started to emphasize and to recommend the superior lateral approach, and to think about another way to fix these fractures than fixing the head. Because frankly, I think we do a mistake in the conception. We want to fix the head where it's not like the femoral neck fractures where you have to fix the head. That's the problem. But as you know, the humerus has no neck or very little neck. And the key point is really the fixation of for me, not the tuberosities, not the head, the greater tuberosity. You have to fix the greater tuberosity. If you succeed in this operation, fixing the greater tuberosity in the right spot and getting the healing bone with the diaphysis, you're done. The job is done. You can have a necrosis, but as you know, the vascular necrosis, post-traumatic vascular necrosis are very well tolerated, not like the avascular necrosis. Usually they are pain-free, except if you have these fucking screws, locking screws, which destroy the glenoid. So what I want to emphasize that you can get the same locking technology that you love inside a nail. And there is no backing up of the screws, no pull out of the screws if you have a good nail with locking technology, number one. And if your screws are directed in the right direction, which means from posterior to anterior to fix the greater tuberosity, and from anterior to posterior to fix the lesser tuberosity, you don't need anything to fix the head. I've never put a single screws in the humeral head, listen to me, for 20 years. I've stopped. No screws in the head.
Okay, Pascal, if you want to summarize this discussion, because whatever you use, the most important, the key point is the greater tuberosity and less tuberosity is the cuff. You have to repair the cuff first.
Exactly.
The second point, even there is necrosis, the most important is the cuff. Okay? Exactly. And I think that everyone has agreed with osteosynthesis, or Joaquin promote hemiarthroplasty, but I will show you that with hemiarthroplasty we have a good result. So yeah. I think that the most important is to avoid a big mistake. What is a mistake is not to anatomic reduction of the greater tuberosity. If you are not able to do that, you do a big mistake. Do you agree with that?
Exactly.
Okay, thank you.
And one of the messages is no reduction in the emergency room for these fractures, but in the operating room.
Yes, thank you, Jide. And we have to progress, and this is the second case for you. It's 58 years old, male, sedentary, right dominant, fracture dislocation with 4 fragments, and he was treated conservatively. And I visited this patient 6 months after this fracture with these X-rays. See that this is a malunion of the greater tuberosities, and I did. There is a joint here. There is a problem, maybe a little necrosis or arthritis. And regarding the shoulder, the patient is not so bad. The main problem for him is not the pain; is a stiff shoulder with loss external rotation and with loss internal rotation, because elevation, forward elevation was 140 degrees and is not so bad. And you see that the constant score, the function, and it has more mobility because stiff shoulder. He did a lot of physiotherapy. He asked me, I will summarize that. The CT scan, and this is a CT scan with 3 planes. We have the video if you want to show you. And the decision was, what are you doing for the patient, not for the pain, to recover more mobility in external rotation and internal rotation. So please, can you vote for this patient, 58 years old, after conservative treatment of fracture 4-part fragment, valgus, with a malunion of the great tuberosities, with a horizontalization of the head, and there is a beginning of necrosis, and this is a proposition. I ask now the expert, maybe Carlos. Carlos, what do you propose for this patient? I can show you this if you want. If you want to see video, I can show you video.
How long are you after the trauma, after the fracture?
6 months.
No, I think that is a mid-age male, no pain.
No pain.
The only concern is rotation.
Yes.
But the greater looks more or less in the right place. It's just the humeral head, as I can see in the CT scan. So, to be honest, I have little things to offer him to improve rotations, because I'm not really sure that any surgery can improve rotations in this patient that has 140 degrees of forward elevation, no pain. So, and just 6 months from the fracture. So I probably would give a chance to conservative treatment.
Okay. Bernhard or Joaquin? Joaquin?
Yeah, I can go first. So a couple of things. On those CT scan cuts, I think the joint surface is irregular. And it's only 6 months, and his VAS for pain, you said, is 2 out of 10, but I suspect that the way that the head looks, eventually his pain will increase, maybe in a year, maybe in 2, maybe in 3. So if I were to offer surgery, I'm thinking that I have to replace the humeral head somehow. Just because I'm not thinking about getting motion to him now, but also to prevent pain getting worse down the line. So if I were going to offer him surgery, I would offer him probably an arthroplasty. And then what I don't know for sure is if he will get a better result with a hemi or a reverse. And I'll tell you why I'm saying that. With a hemiarthroplasty, you could do a very, very small humeral head cut and use a small metallic head or pyrocarbon, so that the head to velocity relationship is acceptable. And that combined with soft tissue releases may get you the motion that you want. But I think it's less predictable than a reverse, where you can be more aggressive with your soft tissue releases, and potentially by moving the humerus away from the glenoid and having the reverse geometry, maybe get more motion in external rotation. So I am not 100% sure about which one will give this patient a better long-term outcome. One of the two, but I'm not 100% sure.
58 years old. Bernhard?
At the beginning, I was just thinking, it's only the malunion of the greater tuberosity. Then there is a partial head collapse, and still posterior is a problem. And he is pretty good right now after 6 months. To improve him substantially, I would hesitate to do surgery now. And if he will be worse with time, what I expect, what Joaquin says, then I would probably go for replacement. And in this situation, if they suffer enough, my only replacement that works is usually reversed arthroplasty in these situations.
Pascal, what do you think?
Pascal?
So according to our classification, this is a type 1 fracture sequela, which means that it's a collapse of the humeral head or necrosis and necrosis. And I think this is a nice case of Philippe and Jean-David that you presented, because this patient is at 6 months after the trauma, and there is a decision to take. Because normally for those fractures, you need 1 year to 18 months to really recover from this fracture. So that's an option. But the other option is saying that if we wait so long, we're going to destroy the cartilage of the glenoid, and then we will miss the possibility to do a hemiarthroplasty, because 58 is still young. You know, if this guy is active, I mean, it's still young. So I will discuss with the patient to know this will and this level of activity. But we have published many papers on this type 1 fracture sequela, and the valgus type gives very good results with a hemi or a total if the glenoid is destroyed. But in this case, precisely, the glenoid cartilage doesn't seem to be destroyed, and I would go for a hemi. And as it has been said, I mean, there is almost no cut of the humeral head to do, because the head is collapsed. You just have to make a small slice of osteotomy, and then you have to prepare the humerus. And of course, you should not oversize the head. But I think with a hemi, nicely placed, you can do a good job and give back some rotation to this patient. So for me, I will go for a hemi. If this guy really is active, and I don't want to wait for another 6 months or 1 year before the glenoid is destroyed.
I think a very important point also when you do arthroplasty in these patients is to avoid an osteotomy of the greater tuberosity. I think, like Dr. Torrens says, the tuberosity is actually where it should be, is that the head is not where it should be. And that's why you need such a small cut. But years ago, our mentors at Mayo used to do osteotomies of the greater tuberosity, and it was a disaster. So you have to adapt the position of the head to the new geometry of the humerus, as opposed to taking everything apart. That, I think, is a very important point.
And on the other hand, to manage the subscap, do you think an LTO is a good idea to replace at the good position the lesser, or do you do it anatomy? Or?
I would do a LTO in this case, and lesser tuberosity osteotomy, because you need to reposition and to regain and to release the subscap and to open the rotator interval, of course. And then you can have very good fixation of the subscap with the piece of bone and cerclage with loop sutures. So, but I think we have published many articles, but there is one article specifically on type 1 fracture sequela that we published in the American GPGS, and we have shown that with Gregory Moineau, one of my fellows, we have shown that the valgus type was a very good type for having good results with hemi or total, and the bad type is the varus. When it's in varus, the high risk of fracture of the greater tuberosity when you put a hemi or any prosthesis or a reverse, and the valgus type is a very good prognostic.
I also would agree, Jean-David, with the LTO. The other benefit is that once you get the tuberosity out, you can really see from the front where the head collapsed, and it really helps you make your cut. It gives you like a really good view of where the head finally healed in a collapsed position.
And in this case, a small stem, I think, with cement is very interesting, because what is important is not to get fixation of the stem in the medullary canal. What is important is to place the prosthetic head exactly at the level of the greater tuberosity. And then if you use a small stem with cement, you can really adapt nicely the position of the head.
Yes, because I think that the difficulty, Pascal, is to put the good size of the humeral head, because there is a malunion, lot of stuff. Do you have a planning today to do this hemiarthroplasty? Do you have a planning like a reverse?
Yes. With the software, you can plan this case. But what you should remember, if you don't have any planning, is that the head is always too big. You know, especially in this case where the goal is to give back some motion in internal rotation. The tendency is always to oversize the head. So Usually, if you decide for a size, take one size under, and it will be the right size.
Okay.
And so in this patient at 6 months postoperatively with no pain, 140 degrees of elevation, do you wait or do you do the hemi?
As I said, I will discuss with the patient to see really his level of activity and what is his will or her will, and then I will discuss with him. Of course, if he's good forward elevation, no pain, we can wait. But again, the risk is to then have to replace the glenoid, and as you know, glenoid loosening is the problem in young patients.
Okay, the result of the poll is very interesting because how many people? Maybe 60 people. 33% hemiarthroplasty, 30% reverse, 80% anatomic, on 12% conservative treatment, 6% osteotomy on graft. So the winner is hemi or reverse. So I think that the most important, I didn't operate this patient because I saw this patient at 6 months and he was very demanding regarding the result, and I was afraid about the results because you see that forward elevation is 140, external rotation 10, external rotation in position 260, and I decided to see again the patient after 6 months, and I didn't operate the patient because it was not he was very demanding regarding the result, and I prefer to refer 6 months for the physiotherapist. So thank you for your advice because it's very interesting. And even when you show a clinical case on Pascal, I agree with you. The discussion with the patient is very important, very important. So you publish good result in hemiarthroplasty, of course. I think that is logical. Without any osteotomy of the great tuberosities, this is a key message. This is a key message. Don't touch to the great tuberosities, accept the malunion and put a hemiarthroplasty, but sometimes you don't feel the patient and you don't operate, and I think that is better than to do a big mistake. I will show you in 6 months and maybe again, and to show you the result of conservative treatment. The last case, Jean-David.
So she's a 46-year-old lady, right hand dominant, and I saw her 5 months after a 4-part fracture when she was skiing, and she had an ORIF with a plate. And when I saw her, she was very, very painful, and she was very stiff with limited active and passive range of motion. And it was difficult to assess her rotator cuff because she was so painful, but the supra and the infra looked quite weak. The subscap was not too bad. She was not pseudo-paralytic because she was stiff, so it was not possible to assess that precisely. And she had no external rotation lag sign. And this is what her X-ray looked like. And so at this point, so she has clearly a malunion of the greater tuberosity. The head is not perfect, but it doesn't look too bad, and no signs of AVN. And the head looks healed to the shaft, and the tuberosities look healed also, although in a bad position. And so what would you do now, Bernhard? Would you do more exams? Would you do nothing? Would you do some rehab? Or
I would like to have a CT scan first before I decide.
So we'll move on to the CT scan quickly because there is no point in waiting. So here you have the axial views. It's an arthro CT, and she had an injection, a glenohumeral injection at the same time for pain relief. Here are the coronal views.
So,
and just to show you the muscles, and then we're good. And so the muscles don't look too bad.
She's young, they're not too bad.
Yes.
Yeah. So where I disagree is that the head is not in a good position. It's very much in varus.
Yes,
I think
but
it's
there's no
exactly
collapse like before.
Exactly, yeah, but it's so fixed in varus, and that's exactly what we don't want to see with osteosynthesis. Here I completely agree with you, Pascal. And the situation is bad function, very difficult situation. And when we analyzed our 120 locking plate failures and reported that what we could see, whatever we did in between, it frequently ended with a reverse prosthesis. So I fear a little bit that this situation is not good enough for anything else than a reverse. And also she's 46. But I cannot see, hardware removal will not improve her. Arthroscopic release, it will not. We checked all these things. Revision OREF could be an option, but to osteotomy the head and the greater tuberosity will be difficult too. Probably the best option for her would be a reverse, but she is young. Huh?
Yeah, so that's the problem. She's young, and it will be a poor reverse anyway, because it will be a reverse without external rotator muscles. So it's a disaster.
She has the greater tuberosity. She still
but it's in bad position.
There. Yes,
it's a disaster. That's why I really hate this surgery, because it burns the bridge. And when the bridge is burned, you cannot cross the river anymore.
Pascal, I can show you tons of nails with such situations as well. So it does not depend on the implant. It depends on the surgery.
No, it depends on the approach. GD, can you show the AP view and the lateral view?
Yes,
I think it's very interesting, the X-rays. It's very interesting. Show us with your arrow, where is the greater tuberosity?
Can you see my arrow?
No, not really.
No. Wait, let me see if I can show you something. I'm not sure,
but anyway, it's
yes, you can all see. Yes, it's
on the lateral view.
On lateral view, we can see it. Yes.
And again, it's technically almost impossible to put it laterally. Again, you place your suture on the greater tuberosity. You're coming from the front. So you put the arm in internal rotation, and it's easy to put your suture in the greater tuberosity. But then, what is the maneuver of reduction? It's external rotation. So then you cannot put your plate. So what do? You come back in internal rotation. And then
but Pascal, the head is in a very bad position here. That's not the problem of the
head. Who cares of the head? Nobody cares about the head.
You said before varus is not good. This is varus now.
But it's a varus with no cuff. So who cares? It's going to necrose anyway.
She still has cuff on the greater tuberosity posterior. That's not fixed in the correct position. I agree. But the problem is really the head here, huh? And the cuff that is posterior fixed on the greater tuberosity. That's just not a good reposition.
Explain to me, how do you do to put a plate laterally on the humerus when you're with the arm in abduction external rotation? Because the position of reduction of the greater tuberosity is abduction external rotation. How do you put your plate coming from here, from the front, there posteriorly?
Now you have stay sutures.
You can do it, but nobody can do it.
Yeah. I think, we can discuss endlessly. I don't say anything against nail. I'm just not good in nails. And many people are also not good in nails.
No, but just tell us how you do.
I can show you, and we have just accepted 400 cases in JVHS now with plate osteosynthesis, that you can fix tuberosities. You can fix tuberosities with plate as well.
But so now we are 7 months post-op, and
so there's no.
And so her pain has improved a little bit with the injection. Her range of motion has improved a little bit. She has some pain on the infra and the supra, but she recovered some strength. And so, Joaquin, what would you do now? We're 7 months. It seems she is improving a little bit, but as you've seen, it's not very good situation. Would you wait? Would you do a reverse like your colleagues, or?
So we are still at a phase where you have not removed the plate, right? Because I saw an X-ray that this is before plate removal.
Yes, someone is playing with the arrows, but I want to wait a little bit.
Okay, so at a minimum, I will do the plate removal that you, or I think, already showed in another X-ray, because I worry that those screws are very close to the glenoid.
Okay.
I didn't understand the main complaint. Is she complaining mostly of
She's
pain?
complaining of pain. Her visual analog scale is 6 out of 10, and her range of motion is very limited. 100 degrees of elevation. She has external rotation. That's not too bad, but her elevation is very bad.
Yeah, I think I have to figure out where is the pain coming from. You know, if she has occult ABM.
What she says is that when she had the injection, the glenohumeral injection, she had complete relief for 2 weeks.
Yeah, but that doesn't tell you exactly that if you do an arthroplasty, the pain is going to go away completely. You know, I mean, it helps for sure. I think at a minimum, I would do plate removal because now whatever had to heal is already healed. And then maybe let the patient recover from that and then see where she is. If the patient ends up needing an arthroplasty, probably reverse is more predictable because she lacks so much active elevation. But I agree with everyone in the panel that somehow you have to restore the function of the posterior rotator cuff. Sometimes it is possible to advance the tuberosity to a better position. Sometimes you have to think about tendon transfers.
I think that probably at this point, I would suggest, as he's improving a little bit, just to remove the plate and being able to take some cultures, because in all these cases with hard surgery because of fracture, I suspect a low-grade infection. So it's a good time to remove the plate, take some cultures, and be prepared for the next step that probably will be to do a reverse.
You know, everybody wants to remove that plate and maybe do arthroscopy and release and biopsies. So what we have seen in the blocking plate failures, if you do this, that's usually not the end. It continues. They are not happy enough with plate removal and capsular releases, and they frequently end with a prosthesis at the end. That's frustrating. So better do the osteosynthesis well at the beginning, Pascal. Okay.
So me at the time I had asked to
just to let you know the result of reverse prosthesis in fracture sequela is 45 points for the constant score. So it's miserable. So that's, you end up with the prosthesis with the reverse. I agree with you, but the constant score, the SSV score is miserable. Whatever you do.
What's the other option? You know, if you want to give her back elevation active that she does not have, what are the other options? If at
that time I had asked Gilles Valche because I wanted his opinion, and he said never do surgery on a fracture before 1 year post-operatively. And so I listened to what he told me, and I waited, tried to rehab her a little bit. And then after 1 year, I decided to do what Joaquin proposed and Carlos, to remove the plate. I didn't do biopsies because I was not afraid of infection. Her scar had been always very good looking, and she had no signs of infections to me. And I tried to burr arthroscopically a little bit of the impingement from the lesser tuberosity, and I removed the plate also arthroscopically because this is what we do in the department, although I'm not sure this is very useful. And this is her 1 year post-op. So she has no more pain. She's very satisfied. And her range of motion is absolutely not perfect, but I think she's not too bad and maybe better than with a reverse at 46 years old. And so I'll see how she goes on, but she's quite happy now.
Very good results. Congratulations.
That's good. So if you have that, you're happy. That's clear. Don't do anything else. Unfortunately, that's not the normality in this situation.
But my question is it worth trying, or do you think it's better is the reverse worse after trying this than doing it straight away? That's my question.
No, it's just a surgery more where you risk maybe infection, but no.
Okay.
The reverse will not be better than this anyway.
Okay, thank you guys. It's 10 o'clock. And very nice discussion. Thank you, Pascal, Carlos, Jost, and Joaquin to take time for these discussions. It's always the same discussion, it's fraction. We are very happy to show you that there is no answer, and many people ask a lot with your experience. And the next shoulder board will be posterior instability. And we are lucky to invite Moroder, who work a lot on posterior instability. Buddy Savoie, he did a lot of arthroscopic, and Matthew Provenche, Palladini from Europe. And it's always the first Tuesday at 9 p.m. And you can see this shoulder board in replay next week on the platform Shoulder 3T. And thanks to do your registration, because now we have for the next shoulder board 60 registrants. And thank you a lot for to take time on this not too easy in this period. And I wish you a good health for you and your family. And thank you a lot. Bye-bye.
Thank you very much. Bye-bye.
Thank you very much.
Thank you.
Thank you very much.
Bye-bye.
Thank you,
Bye-bye.
Pascal. Thank you, Joaquin.
Bye.
Carlos.
Thank you very much.
Bye.